So welcome everyone to the 2025 Health Studies User Conference. I'm really happy to be hosting this again. We've been running this conference for over 20 years with University College London and NatSen. And as I say each year, I've been there for all of those conferences. So the aim of the conference is to provide a forum with for data users, data producers, data funders, policymakers, and more, so that you can all hear from each other, so that we can showcase the fantastic health survey data that we have, both the cross-sectional survey data and the longitudinal and cohort data that we hold and provide access to at the UK Data Service, and to showcase the research that's carried out with those data. So, as I said at the start, we have around 260 people registered to attend today. So hopefully there'll be some lively discussions, Q&A sessions throughout the day. I shall introduce our keynote speaker for the day. So Lola Oyebode is a Professor of Public Health at Queen Mary University of London, where she leads the Centre for Public Health and Policy. In 2012, during her specialty training in public health, she spent 9 months with the Health and Social Surveys Research Group at University College London, where she was introduced to the Health Survey for England, which has been important to her work since.
Hello, everybody. So, well, I've just had an introduction, but yes, I'm Professor Oyinlola Oyebode, also known as Lola, and I'm currently at Queen Mary University of London, and really grateful to be invited to give this keynote on one of my favourite topics, which is the use of the Health Survey for England in policy making and monitoring. And I think it sounds like it'll be very, very relevant to the next session that we've got in this conference. So my plan for the talk is to give you a brief introduction to the Health Survey for England for anyone who's less familiar with it, and then talk through examples of how it has been used at each stage of the policy cycle. So from agenda setting through policy development and implementation, and finally in evaluation and monitoring. And then I'm going to give an overview of some of the strengths of the Health Survey for England and why it is so appropriate for use by policymakers, and then finally talk about some possible future directions. So here we go with the introduction to the survey. I don't know how many people in the audience can tell what year this slide is representing. So I'll give you a second to look at it, and then I'll tell you the answer. It is 1991. So this is the year that John Major, our Prime Minister at the time, said that Britain was going to be at the heart of Europe. And it's also the year that apartheid laws were ended in South Africa, Freddie Mercury died, the Gulf War ended, the World Wide Web, over here, this picture is the World Wide Web, was opened to the public for the first time. In the UK, Bryan Adams spent 16 weeks at #1. And for anybody from Birmingham, this statue was unveiled in Centenary Square then. But it was also the first year of the Health Survey for England, so a very long time ago now. And in order to understand this 1991 start, we actually go back a little bit more to 1988, when the Chief Medical Officer, Donald Aitchison, wrote a command paper called Public Health in England, here's a picture of it, which highlighted a lack of a specific focus at the centre with the capacity to monitor the health of the population and to feed the results of any analysis into the development of health policy, strategy and management. And so the recommendations that were made in this command paper led to the setup of the Health Survey for England. And although the 1991 survey was more of a pilot and it started more in earnest in 1992. So the Health Survey for England is a survey which is funded by the Department of Health and Social Care, and still, as originally envisaged, it's designed to allow the government to plan health services and make important policy decisions. It samples a nationally representative random cross-section of the free living general population of England, and an interviewer visits a household to recruit up to 10 adults and up to 2 children in that household. The interviewer collects socioeconomic data, information on health and health-related behaviours with a survey, questionnaire, and also measures height and weight. And then if the household consents, then a nurse will then visit the household to take physical measurements such as waist and hip circumference and other things, and blood pressure, and also collect biological samples, so things like urine, spit and blood. And also the nurse collects information on medication use. So this, I know this is so tiny, you probably can't see it very well, but this tells you a few of the measurements that have been collected by the Health Survey for England, including blood pressure, grip strength, lung function, walking speed, and also the analytes that have been collected from the blood, saliva, and urine samples. So just gives you an idea of the range of things that have been done in the Health Survey for England, but also the consistency with which they've been done over the years. So now the next part of the talk is where we're going to think about how the Health Survey for England was used by policymakers. So the intention behind the creation of it is very clear, but how has it actually been used? And this part of the talk is relying heavily on findings from these 3 papers, which include 2 that are now a decade old. So looking at the use of health examination data from the Health Survey for England in government policy development and implementation. And this is the use of the Health Survey for England in obesity policy making and monitoring, and then a more recent paper. And so just to tell you a bit about the studies behind those. So the 2 older papers are a result of some studies that I did when I was at UCL in 2012, which involved a very systematic search of all the chief medical officers' reports, command papers, and clinical guidance that had been published at that point, to look for references to Health Survey for England or to the data from the Health Survey for England. And I also interviewed stakeholders at the Department of Health, which is what it was then, and the Health and Social Care Information Centre. So I spoke to them a lot about actually the barriers and facilitators of using the Health Survey for England in policy making and monitoring, but I also got more examples from them, and then retrieved more policy documents that were identified through those interviews. So that was a very, very systematic piece of work to try and map all of the places that the Health Survey for England had been used at that time. But then in 2023, there was a consortium of people who are working across the world, so people who are running health examination surveys in Europe and in the Americas. And we worked together and asked policymakers, again, for examples of their use of the examination data in national or regional policy making, and also some snowballing. So have they heard of other people who might give more examples? So this was a less systematic way, but in this study, we collected ways in which health examination surveys globally had been used in policy making and monitoring. And I'll rely on information from both of those studies in the rest of this presentation. And what I ended up with in 2012 was a very large table, which looked something like this. Actually, I just need to make that a bit bigger. There we go. So I had all of the different measurements down one side, and then I looked at the different places in the policy cycle that they might have been used. And this is a very small excerpt of that, just to show you kind of the number of different examples that I had got to choose from, which I'm going to be talking about now. But one of the examples that didn't fit into that table wasn't an example of how the Health Survey had been used, but actually an example of what happens, a counterexample, what happens when you don't have the data. So this was, somebody told me the story about the Health of the Nation 1992 obesity target. So this was a health policy in 1992, and this was the obesity target that they put into that policy to reduce the proportion. Their goal was to reduce the proportion of men and women aged 16 to 64 who are obese by at least 25% and 33% respectively by 2005 to no more than 6% of men and 8% of women. And at the time that they made that target, they had 2 small surveys. So they had a survey from 1980 where they found that, in fact, 6% of men and 8% of women had obesity. And then they had a survey from 1987, which suggested that 8% of men and 12% of women had obesity. If they had had year-on-year data at this point, they might have understood a bit more about the kind of trajectory of that increase in obesity, which would have meant that they could have set a target that was a little bit more realistic, but also perhaps that they would have taken more urgent action sooner. But instead, that kind of trajectory, that steep increase, was unknown. And what we know from the Health Survey for England now is that, in fact, in 2005, 23.1% of men and 24.8% of women had obesity. So you can see that that target was in no way met, but it's because really the target wasn't realistic at all. So now looking at some of the examples where the Health Survey for England was used, this is, first of all, in agenda setting. So actually identifying where health policy is needed identifying health issues that are amenable to policy action. And that was the main way that we found that the Health Survey for England was useful to policymakers. And here is one example which was relating to chronic kidney disease. So in 2003, there was a tiny, tiny percentage of the population who had chronic kidney disease according to GP records. And by 2010, this had risen quite considerably. And so there were a team of people who were interested in this and realised that there was underdiagnosis of chronic kidney disease and decided to do some objective measurement of chronic kidney disease in the Health Survey for England. And they did that using serum creatinine in the blood sample and albumin to creatinine ratio in the urine samples. So they had this objective measurement of CKD in the Health Survey for England in 2009 and 2010. And this is what they found. So this graph here is showing you the prevalence of doctor-diagnosed chronic kidney disease by age and sex. So this is when people were asked, do you have a diagnosis of chronic kidney disease? And what you can see is this is very small numbers, and we go up to kind of less than 4% of people in this age group, 75 plus age group. So that was the doctor diagnoses. But then when they looked at the survey-defined chronic kidney disease that they were doing based on the blood and urine samples collected, the prevalence is much, much higher. So you can really see this dramatic underdiagnosis, because now when you look at the stages 3 to 5 in that 75 plus age group, you've got more like 25 to 30% of people who've got chronic kidney disease when you actually look at their biological measurements. So actually the team went further than this, because as I said, we'd got this situation where the number of people on GP records had increased dramatically. And there were lots of concerns that actually, because obesity rates were increasing, that chronic kidney disease was also increasing fast. And the team were able to, again, use the Health Survey for England to go back and explore the trend, because they used the stored blood samples from the 2003 Health Survey for England. They didn't, unfortunately, have stored urine samples, or they didn't have access to those, but they were able to look at that kind of blood analytes over time at those two different time points. And this is what they found then. So in this graph, you've got two different ways of assessing the chronic kidney disease at two different time points, so 2003 and 2009. So in the all, for example, you can see 2003 here in white, and next to it, 2009 assessed in the same way. And then next to that, you can see 2003 in a different way, and 2009 to 10 in that same way. And what you can see from this data is that actually, so even in this 75 plus age group, 2003 is higher than 2009. 2003, using the other method of diagnosing CKD from the blood sample, again, the 2003 is higher than 2009. So actually what we could see was that the trend was actually decreasing. So it was the reverse of what the primary care data showed. And this was really important and useful because actually, of course, there was an increasing awareness and there was increasing diagnosis. And people were concerned because obesity was increasing, which is a risk factor for CKD. But actually, what the analysis of the Health Survey for England showed was it was probably more important that hypertension was reducing, and actually cigarette smoking was also reducing. And that actually meant that the burden of CKD was reducing. So even though detection and diagnosis were increasing dramatically over that time period, the actual burden of disease was reducing. So this is so important when you're working out what to do in terms of policy, that you understand what the trends are, which is what you can do when you've got kind of this data over time. Okay, so the next example is about policy development. And here I'm using the example of the Department of Health and Social Care calorie model, which I've got a picture of on the right. And this was a model that was used to test various different policies to try and look at the outcomes of those. So those policies were ending the sales of energy drinks to children, mandating energy labelling of food and drink in out-of-home settings, restricting price promotions for high fat, salt and sugar foods, and restricting checkout, end of aisle and store entrance sales of those foods. And you know probably that some of those policies are in place now as part of the 2020 obesity strategy. And the Health Survey for England, again, contributed the age group and sex-specific height and weight data that went into this model. So again, that data that underpins the modelling to allow us to know how these things might change obesity prevalence. And so my last example is for monitoring and evaluation. This is another area where the Health Survey for England, just like that identification of issues amenable to policy, this is another area where the Health Survey for England is really incredibly useful to policymakers, monitoring and evaluation. And the example that I want to give you is about the evaluation of smoke-free legislation. So in 2007, there was a ban on smoking in public places, but there were concerns raised that if people can't smoke in pubs, they might stay at home and then smoke at home instead. And then the children of smokers would be more exposed to secondhand smoke than when people could go out and smoke in other places. And this was examined through examination of salivary cotinine. Cotinine is a byproduct of the metabolism of nicotine. So again, a nice objective measure. It's not just asking people, do you smoke at home, but actually being able to tell, are these children exposed to secondhand smoke? And here is the graph that shows the monitoring. So you can see really that there was nothing to worry about. So the red shows the households where the parents smoke. And so this is the salivary cotinine for children. And you can see all the children are in blue. The children of parents who don't smoke are in green, but the important group here are the children whose parents do smoke. And if those parents were now smoking at home, then you might think that those children were going to be more exposed, but actually they're less exposed. And the decrease was fastest around the time that this smoke-free legislation came in, so when it was being debated and when it came in. And potentially actually because parents were thinking, okay, well, it's so important that I don't smoke in front of these strangers in the pub and don't expose them, that actually I don't want to expose my children either. So it might have actually increased the number of people who didn't smoke at home because the importance of the topic. So again, a very useful thing when there are real worries about the potential unintended consequences, that we can actually see, well, whether or not those unintended consequences are happening. So having given you a few of those examples, the next thing that I want to do is talk about some of the strengths of the Health Survey for England, which actually facilitated some of these examples. So one of the key features of the Health Survey for England is the national sampling frame and the random sample. And that means that we know what the non-response rates are. And because we know what the non-response rates are, and they can actually be estimated by population group, then we can make weights so that it's possible to use this data to produce nationally representative findings that have external validity, so they can be generalized. And that's not the case for lots of other large data sets that exist. So something like Biobank, for example, which relies on volunteers. You can't make generalizations to the whole population from a database of volunteers, because those people will have there'll be some bias, some selection bias there, that you can't even really properly measure when we've used volunteers. But also the national sampling frame is important because it captures the health burden for those people who are not seeking care. So again, other data sets, like, for example, we looked at the GP records for the CKD, for example. If people are not seeking care, then we don't know what their health burden is, but we can actually assess that using the Health Survey for England. But also, it doesn't matter where the population is receiving care, because the other thing is that people might go to private healthcare, they might go to third sector organisations, and then again, those records aren't necessarily captured in routine data. So this was definitely a benefit in terms of that CKD example that I gave earlier. Then, oh, well, actually, I'll just quickly tell you that on the right, again, I'm not sure how clearly you can see it, but this was a paper that was forecasting trends in obesity across Europe. And England is right at so this is the score, this is a table where they gave the data a score based on whether obesity was from measured data, whether it was a national sample, the sample size, and whether they could access the data. And we can see that England scored the highest out of all of the countries in Europe. And actually some of the countries, they only had 1 year of data. So they said, we estimated a flat trend for those countries. And that's almost certainly not true, is it? So it's really, really valuable that we've got this very, very regular national sample that we can really generalize, and really valuable in lots of places. So then another benefit of the Health Survey for England is this objective measurement, which means that we can get the undiagnosed disease. So this again helps us because we can actually get that cascade of care. You can understand, first of all, how many people are diagnosed, and then of those people who are diagnosed, are they being prescribed medication, because the nurse asks that, and are they taking that medication? And then for the people who are taking it, we can also see, so is their disease controlled? And this is really helpful. So you can see, you know, is somebody taking a statin or are they taking an antihypertensive? And then is their condition controlled? And then you understand which parts of the health service are working well. So is it diagnosis, is it treatment, or is it control? Which of those parts are working well or not working well? Okay, so next, then the standardized methods I think are very, very useful. So again, when you think about something like height and weight, then of course you can get in primary care data, people might have their height and weight recorded, but you often don't know, was that a self-report, or if they were weighed or measured, had they been asked to take their shoes off? I mean, it's very similar actually with blood pressure. I actually got to go and do one of the nurse trainings when I was at UCL back in 2012 for the Health Survey for England, and learned about how very careful they are with the blood pressure. So people have to have their feet flat on the floor, etc. Whereas when you go to the GP, sometimes they don't ask you to do those things. And so there's going to be kind of a variation in the way that data is collected. But when we've got the Health Survey for England, we know that this is a standardized protocol. And so you can compare data from various different locations, and you're not thinking, oh, but it might be because they're recording things slightly differently, they're assessing things or measuring things differently. And not just does it mean that we've got that comparable data across locations, but also across years, which you could see from that salivary cotinine, the evaluation of the smoking ban. It's so useful. You don't necessarily know what policies are going to come up, but if you've got that outcome data and you've got it for several years, you're able to use that as an evaluation, rather than thinking, oh no, we don't have a baseline. Actually, because we've collected this every year and you're collecting it in the same way, we can look at the changes. When I showed you that slide at the beginning, the 1991 slide, think of all of the things that have happened since then. In 1991, the World Wide Web was first opened to the public, and now probably almost everybody uses the internet almost every day. So there are some absolutely huge changes, and yet we've collected height and weight the same way all the way through. And I think this is really, really valuable, because it means that we can get these trends. Again, yeah, I'm just showing you a trend on the page at the same time. I also mentioned whether the data can be comparable across countries. I mean, this isn't always the case, but where there are really gold standard ways of measuring blood pressure, for example, or measuring height and weight, it also means that we do have this data which is comparable across countries, because where they've done health examination surveys, they've probably used the same protocol. And that, again, is very useful, kind of benchmarking across the country, and again, understanding how our policy might have resulted in our health outcomes compared to other countries. And in fact, I mean, just for us in the UK, of course, we've got Scottish data, we've got Welsh data, we've got data in Northern Ireland, and sometimes policy changes are different across those 4 countries. So it's very useful to be able to compare. Okay, yes, and then finally, just to mention that the people who take part in the Health Survey for England are asked for consent for their data to be linked to vital statistics and also health records. And this means that although the Health Survey for England is generally a cross-sectional, I mean, it's used cross-sectionally often, or it's the trends, so that kind of series of cross-sectional studies, we can also do longitudinal analyses. And this is just one in which you can see the people who are eating different, reporting their consumption of fruit and vegetables from down here, this group of people who eat less than 1 portion a day, all the way up to these people who eat 7 or more portions a day. And then you can see their survival because of the link to the mortality data. So that's also very useful, because again, it's not the underlying sample, it's a nationally representative sample. So we don't have some of those selection biases you have in other longitudinal studies. Okay, so finally, I was going to talk very briefly about some possible future directions or thoughts. So first of all, there we go. Yes, so building on the work that I did back in 2012 and that we've done in 2023, I think it would be really useful to do further work that might give us a good idea of the value of the Health Survey for England, to weigh the costs and benefits in financial terms. So it would be quite nice to build on that, to kind of think, okay, what is the cost of running the Health Survey for England? And now let's think about the cost of non-communicable diseases, maybe the preventable burden of non-communicable diseases, because it's usually non-communicable diseases that the Health Survey for England measures, although there has been a time when they did look at the immune response to flu. But I think it would be really nice to try and get that kind of cost and benefit, because I think no matter how many examples we give, it would be really nice to be able to say to policymakers who are kind of deciding on the future of these surveys, okay, this is how much money this costs, and this is how much money it potentially saves, because we understand something more about these diseases and can intervene in the right way. So yeah, that would be one useful thing. And then also, it could be good to do a little bit more international collaboration. And here I suggested producing guidelines on how to use the results of health examination surveys to support additional studies. So the WHO has got something like this for other surveys. So for example, the Global Adult Tobacco Survey, GATS, the WHO produces guidelines that explain how to use the findings of that survey, GATS, to estimate price elasticity of tobacco demand for a country. And that helps countries set tax on tobacco, on cigarette packets. So it would be quite nice to think about other guidelines that make it very easy for people to do some of the frequent study types that health examination surveys can do. So normative studies, where you look at what are population norms, the care cascade that we've talked about already, and health system performance, which is quite similar, and then also global burden of disease and attributable risk. So we could think about how those guidelines are produced and how they might be used around the world. Then other possibilities are thinking about how using more and more digital tools might reduce cost, and that could also include things like point of care testing for some of the things that we're sending blood and urine and spit to labs, but are there some things that could be done very easily actually in the household? And then also wondering whether there might be a way of increasing the marketing or dissemination strategies, because I guess one of the main challenges of the Health Survey for England, and I think health surveys globally, is that response rates are reducing. So they're still much better than some of those volunteer surveys that we've talked about, but those response rates are reducing. So can we put out the message more often so that people understand why these surveys are useful, how they actually have improved health in the UK or in England? And so then they might be more interested or kind of understand the importance of taking part. Okay, so I think I'm well ahead of time, Vanessa. Sorry. But yes, so my conclusions are that the Health Survey for England is used extensively in policy making and monitoring across all phases of the policy cycle, although, as you could see from what I said, mainly it's about looking at those policy issues that are amenable to policy, and also that monitoring and evaluation that is so incredibly useful. So many places where the Health Survey for England has been useful there and actually given us insight that we never would have got any other way. It provides unique data that can act as an external quality control for the entire health system. I think that's really important with the care cascade. So being able to be generalizable, being able to tell us who the health service is not capturing in terms of who are they not diagnosing, who are they not treating, and whose illnesses are not being controlled by the current medicine that they're being given. And then further work could be done collaborating with international partners. I've given some examples of how, and then maybe for future developments could focus on reducing costs and increasing response rates. I think I've got some acknowledgements. Yes, so these are the people that worked on the global paper that I've described. And so that's me finished. Thank you for listening.
Thanks, Lola, for a brilliant presentation. Thank you. I think that's just been fantastic at showcasing how valuable the Health Survey for England is, the linked data to the Health Survey for England as well, and how those work together, and also just population health surveys as a whole.